Hi everyone, I'm so sorry that I was unable to be in class yesterday. Thank you for understanding, and we are ready to start into our psychiatric medications. So this will not be on your exam on Monday. Your exam on Monday will be just the endocrine type medications that we went over with thyroid, steroids, and diabetes medications. If you do have any questions, certainly reach out to me. Antipsychotic medications, one of the main conditions that we're talking about is schizophrenia, because it is one of the first line treatments, if not the only medication treatment for our schizophrenic patients, is our antipsychotics. So I know you haven't gotten psych and CAM yet, so I'm going to give you a little bit of background information on some of these conditions. With schizophrenia, it is a chronic psychotic illness and it affects an individual's ability to think clearly and interpret their reality. It's going to be mainly characterized by disordered thinking and really a reduced capacity to understand what's real. Typically, it emerges during adolescence or early adulthood, so like in the late teens, early teens to 20s. And in the US alone, approximately 2.2 million people have schizophrenia. The primary cause isn't quite known, but it's thought to be related to an imbalance in dopamine. If you don't remember, is a neurotransmitter in the brain, and this imbalance leads to a psychosis, resulting in that impaired function and difficulty for these patients in their everyday activities. Schizophrenia is an often misunderstood diagnosis or condition, and we see a lot of improper portrayals in it within the media, movies, books, TV, those sort of things. But what it is a splitting of one's personality. And this is going to lead to significant changes in who the person once was. And this can kind of come and go. Schizophrenia, it is a complex psychiatric disorder, and it's, like I said on the previous slide, chronic and persistent, and it's going to often lead to inpatient treatment to manage the symptoms effectively until you can get them managed and on a maintenance medication to hopefully make it so they don't relapse. It's important to note what it's not. It's not the same as multiple personalities or a dissociative identity disorder. It is not just their violent outbursts. That is not what defines them, even though it is something that might happen in certain cases. It's not linked to serial killers, psychopaths, sociopaths. Those are other personality disorders, not psychotic disorder like schizophrenia is. So don't let the TV and media portray that to you either. About our antipsychotic medications, especially when we're talking about how they're used to treat schizophrenia, you're going to hear the mention of positive symptoms, negative symptoms. So this is just explaining what I mean by those. The positive symptoms are going to represent an exaggeration or distortion of normal function. This is linked to the increased dopamine activity. So some of these you might hear about are delusions, which are beliefs held true despite really any clear evidence to the contrary. So like we said before, there's a distortion of reality or not being able to understand reality in schizophrenics. Hallucinations, they are sensory perceptions that are only experienced by the patient. This is going to be like you're hearing voices or seeing things that aren't necessarily there. Disorganized thinking and speech. So these thought disorders kind of manifest in the patient as an unintelligible words, loose associations, or some sort of derailment. And they might also display some of that unpredictable agitation or violence and difficulties with their daily activities. Whereas our negative symptoms are going to be caused by the opposite. They're caused by a diminished amount of dopamine. And this is going to involve a loss or reduction of normal function. So that positive symptom is that exaggeration of normal function. Negative is a loss of normal function. This is your blunted affect or like a reduced emotional expression. poverty of speech, otherwise known as like a limited verbal communication. Anhedonia is a lack of interest or pleasure in activities. It may even lead to asocial or apathetic symptoms going on that can contribute to poor self-care. And then lastly, they do sometimes have some cognitive symptoms, including disordered thinking, reduced focus, difficulties with learning, and memory as well. In order to diagnose someone as a schizophrenic, a patient must present with at least 2 of these symptoms for over 6 months, and the symptoms must cause some sort of functional disturbance in their daily life. There's a few dopaminergic pathways within the brain that lead to a lot of these symptoms that we just talked about. So first off, we're going to talk about the mesolimbic pathway. And normally it's playing a crucial role in the brain's reward system. And it's primarily involved in like our pleasure sensations, euphoria, experience during like drug misuse. When it becomes hyperactive, this is what's going to lead to some of those positive, exaggerated symptoms in our schizophrenic patients, like the hallucinations, the delusions, increased aggressions, or hostile behavior. This overactivity in this mesolimbic pathway is what's, again, strongly associated with those positive symptoms and is really the key target for a lot of our antipsychotic medications. The mesocortical pathway is going to play a crucial role in regulating cognition, executive function, emotions, or their affect, which is like their emotional expression. And a deficiency of dopamine within this pathway is going to be closely linked to our negative symptoms of our schizophrenic patients. These negative symptoms, again, are including diminished emotional expression, so diminished affect, impaired motivation, poor social functioning, and difficulty in performing a lot of their daily tasks of our patients. So reviewing the last slide, unlike that mesolimbic pathway we just talked about, where dopamine excess leads to positive symptoms like hallucinations and delusions, in the mesocortical pathway, a dopamine deficiency is going to contribute to the loss of normal functioning. So these are more negative symptoms, and that's going to impact our patients' quality of life and their daily interactions. The nigrostriatal pathway is going to be our pathway that's primarily responsible for regulating movement. It's closely linked to motor function, so disturbances in the dopamine activity within this pathway can lead to significant motor-related symptoms within our schizophrenic patients. So when there's a deficiency in dopamine within this nigrostriatal pathway, it's going to result in disorders similar to Parkinson's disease. You haven't learned about Parkinson's disease yet within your neuroanatomy, neurodiseases course, but Parkinson's, a lot of the symptoms are strongly defined by a deficiency or lack of dopamine. So that's why this looks somewhat similar to that. So you're going to have rigidity, akinesia or bradykinesia, which is slowed movement, tremors, akathisia, which is restlessness. So don't mix up the akinesia, which is like lack of movement or no movement, with akathisia, which is restlessness. They can't stop getting up and moving around. Dystonia, which is going to be muscle contractions. And then when we looked on the flip side of that, are a hyperactivity of dopamine, which can also happen within this pathway with these patients. You can get chorea, which is an involuntary rapid movements, dyskinesia, which is an uncontrolled erratic movements, tics, or tardive dyskinesia, which is going to be due to a chronic blockade of the dopamine 2 receptors from long-term use of antipsychotics. So we have to understand the balance of dopamine in this pathway, especially when we're considering the side effects of a lot of these antipsychotic medications that are going to be used to target dopamine receptors to treat those positive symptoms. We might see a lot of these side effects from these medications in our schizophrenic patients. Neuroinfundibular pathway is going to be responsible for regulating prolactin release. Under our normal conditions, dopamine acts to inhibit the release of prolactin from the pituitary gland. When there's a deficiency in dopamine function within this pathway, it can lead to increased prolactin levels, which can lead to gynecomastia, which is our development of breast tissue in male patients, galactorrhea, which is an inappropriate lactation, amenorrhea, absence of menstrual periods, or other types of sexual dysfunction such as reduced libido or erectile dysfunction. Disruption in this pathway, similar to when we were talking about the nigrostriatal pathway, is often due to our antipsychotic medications that are blocking dopamine receptors. And these are going to be key side effects of that pathway and those medications. Just a chart introducing you to all of these medications, even differing in potency. So you can see we've got low potency, medium potency, high potency. These are all considered first generation or conventional antipsychotic medications. And they all have the same ability to relieve symptoms of psychosis. If you want to recall back to earlier in pharm, the term potency really refers only to the size of the dose needed to elicit that given response. So in potency, it's not implying anything about the maximal effect of the drug. So if we say that haloperidol or Haldol is more potent than chlorpromazine, we only mean that the dose that we have to give of haloperidol is required to relieve those psychotic symptoms is smaller than the required dose that we need to give for chlorpromazine. We don't mean that haloperidol can produce greater effects. When administered in therapeutically equivalent doses, both of these drugs are going to give the same or equivalent antipsychotic response. So remember, potency just has to do with the actual dose. So do we have to give 5 milligrams? Do we have to 10 milligrams? Not how much of an effect that they can have. I've only highlighted 2 of these that I'm going to go over in the next few slides that I want you to be able to tell me are low potency first generation or high potency first generation. You'll see through a lot of these that a lot of them end in azine, so chlorpromazine, loxapine, perfenazine, fluphenazine, and then there's also haloperidol. Haloperidol doesn't end in the azine, but you do still have to know haloperidol. It's a very common drug you'll be seen given in emergency rooms and hospitals. We'll go over the key things I want you to know about those on the next few slides here. Okay, we're going to get a little bit more detail into our medications now. And we're going to start off with our first generation medications that we use for schizophrenia. Remember, these are called antipsychotic medications, and our first generation antipsychotics are also known as our typical or our conventional antipsychotic medications. When we're talking about these, the main 2 that I said on the last slide that I want you to remember is chlorpromazine is our low potency, haloperidol is our high potency that we use quite often. How these work is they're going to work by blocking receptors for dopamine, especially I have that highlighted, but they're also blocking receptors for acetylcholine, histamine, and norepinephrine. We're going to use them primarily for our positive symptoms. They're not super helpful with our negative symptoms as far as treatment goes. So our positive symptoms, remember, are due to an exaggeration. So we get hallucinations, delusions. They'll help with those positive symptoms. These first gen medications have less of an effect or treatment for our negative symptoms. So the lack of motivation, social withdrawal, apathy, those sort of symptoms. So they're going to suppress acute psychotic episode symptoms. They're going to help reduce risk of relapse when we use them in our maintenance therapies. And then it's super important to remember that this is a chronic illness. They're going to provide symptomatic relief, again, for mostly positive symptoms, but they're not a cure for schizophrenia. When we're looking at how long they take to take effect, you're going to start noticing a little bit of an effect within 1 to 2 days, but not any sort of substantial improvement for at least 2 to 4 weeks, and you won't see the full effect of these medications for at least a few months. For specifics on our first generation antipsychotic or conventional antipsychotic medications, let's look at our high potency agent that I said you should get into your head is the haloperidol, which you'll also hear termed Haldol. And this is going to be, if you're going to choose a first generation antipsychotic for initial therapy, you would likely choose your high potency agent like haloperidol for initial therapy over a low potency agent. But again, that's if you're going to choose a first generation antipsychotic. When we're comparing these together, so high potency to low potency, not first to second generation, just high potency to low potency. With high potency, we're going to see more of our extrapyramidal symptoms, those EPS symptoms. And I'm going to get really into detail here on those side effects after a few slides here. With our high potency, though, we're going to see less of our other symptoms that may cause our patient to stop taking these medications, like sedation, orthostatic hypotension, and those anticholinergic effects, so dry mouth, constipation. It is used in acute psychosis, and even though I say it's more preferred if you're choosing a first generation, the choice is going to still involve balancing the risks and benefits on your individual patient's needs and tolerances. When we talk about our low potency agents, the two main ones we talk about are chlorpromazine and thioridazine. They both end in that azine there. And so that has that azine suffix. When we compare these low potency agents to their high potency counterparts, noticing that they're both first generation. So again, we're comparing first generation to first generation, low potency to high potency. Our low potencies are going to have a lower risk of those extrapyramidal symptoms. So that's going to be our dystonia, our akathisia, our tardive dyskinesia. However, this benefit comes with some trade-offs because they generally cause more sedation with daytime drowsiness, more hypotension, getting drops of blood pressure leading to dizziness when they're standing. There's a greater risk of those anticholinergic effects, and this can really significantly impact the patient's quality of life. So due to these side effects and the availability of many other agents, our low potency first generations are often not our first choice for treatment. We typically will choose something else with a more favorable side effect profile. Into a bit more of our specifics when we're talking about these extrapyramidal symptoms. I know that you have heard about the extrapyramidal symptoms a bit when we talked about some of our antiemetic medications last quarter, but let's get into a bit more of what we mean by these. So these three that we're talking about here are going to be our ones that can occur early in treatment, and they're often really manageable. First off is acute dystonia. It's one of the initial extrapyramidal symptoms a patient may experience. It involves spasms of the muscles, particularly in the tongue, face, neck, and back. This condition can be quite distressing, but it's often treatable fairly quickly quickly with medications like diphenhydramine or benchtropine. Another common form is our Parkinsonism. We talked about some of these on one of our other slides when we were talking about our deficiency in dopamine caused by these medications. And you can get those symptoms of bradykinesia, a mask-like facial expression, tremors, rigidity, a shuffling gait, drooling, cogwheeling, possibly a stooped posture. It's going to be similar to the treatment for the other early extrapyramidal symptoms as well, with your benchtropine and your diphenhydramine. And then lastly, we have akathisia, which is going to be characterized by compulsive, restless movements, anxiety, agitation. This can really significantly impact a patient's comfort and adherence to treatment. So our strategy, if we start to notice these symptoms, is going to be, if we can, reduce the dosage of whatever medication we're using or switch to a different type of antipsychotic medication. You can also give them benchtropine or a propranolol to help with some of these symptoms. We'll get in a little bit more detail individually on other slides. I have a slide for each of these early on manageable extrapyramidal symptoms back to back here. I've also tried to include YouTube links to videos showing what these look like in possibly actual patients, or just trying to mimic what these symptoms look like. This video for this one that I have on this slide for our acute dystonia shows a gentleman that comes into the ER with dystonia type symptoms, and they give him diphenhydramine within the ER, and you can see how quickly he improves from our IV diphenhydramine. So I did find that video pretty interesting to watch if you feel like watching it. When we talk again about our acute dystonia, it's going to involve painful, abnormal, prolonged contractions of the muscles. And this is going to manifest kind of in a spasming of whatever affected muscle it is, so the tongue, face, neck, back. In severe cases, though, this can cause even contractions that might compromise the airway, so it can be potentially life-threatening. And it's going to be important to timely recognize and manage the patient. This condition is usually, like I said, early on. It manifests within a few hours to days after initiating treatment or increasing the dose of whatever antipsychotic you're using. Because it's quick onset, it's crucial for both clinicians and their patients to be vigilant about reporting or noticing any unusual muscle contractions. To prevent it, you could try adding benchtropine or diphenhydramine when you're starting treatment or increasing a dose to help reduce the risks of developing these symptoms. And again, that's going to be how you treat it as well. Quickly going through our antipsychotic extrapyramidal symptom of Parkinsonism. Again, it's going to have kind of a range of symptoms, including the bradykinesia, mask-like facies, tremors, rigidity, a characteristic shuffling gait or tremor, a stooped posture. And these symptoms can really impact a patient's mobility and their quality of life. To manage this effectively, the first step is often to decrease the dose of whatever antipsychotic they're taking or consider changing it to something else. If you're unable to do that right away, you can also, for quicker treatment, give them benchtropine is really the main medication that you'd want to give them. You could also do amantadine or anticholinergics. Next, we have akathisia, which is going to be kind of our most common extrapyramidal symptom that we see with our first-generation antipsychotics. And patients that have this akathisia often describe it as like a feeling of inner restlessness. They've got this just compulsive need to just move, and they have these restless movements, heightened anxiety, sometimes agitation. They find it really challenging to sit still, and that can be really distressing. And a patient talks about that feeling in the video I have linked here. To effectively manage it, similar to our other symptoms, you can reduce the dosage or switch medications. You can also try benztropine or propranolol to alleviate some of the symptoms and improve their comfort while you're trying to get their maintenance medication figured out. Briefly introduced benztropine way back when in Q1, but to do a quick overview and remind you about what it is an anticholinergic medication, and it's blocking acetylcholine receptors. And this is going to help kind of restore the dopamine acetylcholine balance within the central nervous system and get rid of some of those extrapyramidal symptoms that we are seeing with patients that are on our, especially first generation antipsychotic medications. You do need to be aware of side effects though. So similar to our side effects of any anticholinergic, they might get dry mouth, blurred vision, urinary retention, constipation. So these effects can be somewhat bothersome to our patients, so just let them know about that. But it's often a very effective option for alleviating these extrapyramidal symptoms if your patient's experiencing them and you're trying to switch or decrease medication. This will be a medication you can put on short term to either decrease the chance of getting the extrapyramidal symptoms or treat them if they do arise. When we're talking about our extrapyramidal symptoms, we've got tardive dyskinesia. And tardive dyskinesia is going to be an extrapyramidal symptom that comes on later after taking antipsychotic medications, typically for a longer time, and it has a less reliable treatment. It's characterized by kind of these oral facial dyskinesias that you can somewhat see in the pictures on the left part of the slide here, where you see this kind of pulling to the side of the face. Maybe their tongue is getting out and protruding and rolling of their tongue. They can get these chorioathetoid movements, which can be involuntary and affect multiple parts of the body, especially, again, the face and lips, but also the limbs. And the problem with tardive dyskinesia is it often may be irreversible and lead to long-term functional impairment. The first step, if you are noticing these symptoms, is to discontinue whatever antipsychotic they're on that's causing it, in order to try and prevent any irreversible damage. And then if appropriate, if they're on a first generation antipsychotic, switch them to a second generation antipsychotic. And one of the preferred ones, if someone was experiencing extrapyramidal symptoms, is going to be clozapine. And we'll go further into detail about what clozapine is in a few slides here. For symptom management, things that you can try, even though I said that it can be sometimes irreversible, is going to be these VMAT2 inhibitors or a benzodiazepine to help alleviate these involuntary movements. If they don't have improvement with that, you often have to refer to some sort of movement specialist for further evaluation or different treatment options, and they may also need to consider like deep brain stimulation. And that kind of goes into a personal story of a patient on antipsychotics that experienced tardive dyskinesia in the link that I have for this one. I mentioned as a treatment option for your tardive dyskinesia was our VMAT2 inhibitors, which is our vesicular monoamine transporter type 2 inhibitors. You can see that all of these end in benazine. I know a lot of these antipsychotics sound very similar, but these VMAT2s are not an antipsychotic. They are used to treat the tardive dyskinesia extrapyramidal symptom or management. Sometimes they help, sometimes they don't, like I said on the last slide here. The mechanism of these, again, by me calling them VMAT2 inhibitors, is going to be inhibiting that VMAT2, and it's going to decrease the reuptake of dopamine into vesicles, which is going to reduce the excessive dopaminergic activity that is contributing to these tardive dyskinesia symptoms. They can be effective, but they do also have potential side effects. A lot of these look like our anticholinergic side effects like sedation, dry mouth. You can also get fatigue and restlessness. And you do really need to monitor patients for any worsening depression or emerging kind of suicidality. You should also look for QT prolongation and if you're using this medication to try and combat any sort of tardive dyskinesia. Okay, we've finished with our extrapyramidal symptoms that can happen, especially with our first generation antipsychotics. And remember, with our EPS symptoms, it's going to be more likely with our high potency, less likely with our low potency. And again, most of these we're talking about are even then more likely with first generation compared to our second generation that we haven't talked about yet. Moving on, we're going to now talk about a different side effect of our first generation antipsychotics, which is our neuroleptic malignant syndrome, or NMS. It is very rare, but it's very serious. It has approximately a 4% mortality risk if a patient does develop this. It typically will present with this lead pipe rigidity, which is really a hallmark symptom, as well as a sudden high fever, sweating, autonomic instability, and dysrhythmias. This typically happens because of an increase in white blood cells, leading to increased CPK, increased liver enzymes, leading to muscle breakdown, and causing that autonomic instability. So with that, they might have fluctuations in blood pressure, which can lead to respiratory failure, cardiovascular collapse, dysrhythmias, and potentially death. It's more likely, again, similar to our extrapyramidal symptoms, to occur with our high potency first generation antipsychotics. So if you're using those, it's crucial to let patients know about what these symptoms look like so they can seek treatment right away. And you can try and do some supportive measures if they do experience these with antipyretics, hydration, benzos. But the main treatment is really just discontinuing whatever the offending agent was that precipitated the condition. You can also, for supportive measures, do dantrolene, which is a skeletal relaxant to help with some of that rigidity, or bromocriptine, which is a dopamine agonist to kind of help, again, restore that dopaminergic balance that caused some of these issues. After you successfully treat neuroleptic malignant syndrome, it's recommended that you wait at least 2 weeks before reinitiating any sort of antipsychotic therapy. And then when you do, it's prudent to try and just get rid of the idea of any first generation antipsychotics, pick a second generation antipsychotics, because they typically have a lower risk of inducing this rare but serious condition. Yes, very wordy slide, lots of side effects that these medications can also cause on top of everything else we've talked about with the neuroleptic malignant syndrome and extrapyramidal side effects. Let's go into the other types of side effects we might see with antipsychotics in general, not just our first generation antipsychotics, but you can get those anticholinergic effects. So your dry mouth, blurred vision, photophobia, hesitancy with urine, constipation, tachycardia. You can get orthostatic hypotension. You can get prolonged QT interval, which can lead to dysrhythmias. They can be quite sedating. So especially with these ones that I just talked about, these side effects of anticholinergic effects, orthostatic effects, prolonged QT, sedation, we see those more often with our conventional or our first generation low potency antipsychotics compared to our high potency antipsychotics. Other things that you might see are induction of seizures or lowering the seizure threshold, neuroendocrine consequences due to the increased prolactin levels, agranulocytosis, which is that kind of abrupt drop in our white blood cell count, which can lead to an increased chance of infection. And then it's going to be, as a healthcare provider, important for you to know about photodermatitis, not only for your patients to protect themselves, but even if you're just directly handling the medication, you can get a photodermatitis if it is on your skin from directly handling the medication. And then big black box warning at the bottom here, all first generation antipsychotics are going to increase risk of mortality if you are trying to use them in an elderly patient with dementia-related psychosis. So you should really use caution when trying to use it in like a dementia-related psychosis. It's definitely not going to be your first go-to option. Here is our list of our second generation antipsychotics. So you can see I have a few more of these that I would like you to remember here. You're going to have the penes, those ones with the suffix of penes, the dones with the suffix of dones, 2 pips and a rip. I don't know if that's going to help anyone, but that kind of gives you a broad spectrum of the medications within our second generation antipsychotics. And these are also sometimes known as our atypical antipsychotics. We're going to go into a bit more detail on these in individual slides. But a lot of these you might have heard of by their brand name. So like aripiprazole is Abilify, lurasidone is Latuda, quetiapine, Seroquel, risperidone is Risperdal, ziprasidone is Geodon. So a lot of these you've probably heard of with those more brand names through TV commercials or advertisements. Like I said, with our second generation antipsychotic medications, I have a few more highlighted that I'd like you to memorize and remember. Your aripiprazole, risperidone, clozapine, olanzapine, and quetiapine. And I will individually name these on why or side effects or those sort of things as we go through the slides here. When we're talking about our second generation or our atypical antipsychotics, these medications are working primarily involving a blockade of dopamine and serotonin. They have less of the blockade of the D2 receptors compared to the first generations. And this reduced blockade of these D2 dopamine receptors might be why they also have a lower incidence of those extrapyramidal symptoms, including like our irreversible, scary one, tardive dyskinesia. In terms of efficacy, though, they're pretty equally effective when you compare them to our first generation agents. However, we're going to prefer our second generation agents in clinical practice because they have less extrapyramidal side effects. They also can treat a little bit more of both positive and negative symptoms. Remember when we talked about our first generation, our conventional antipsychotics, they mainly are treating just positive symptoms with little to no effect on negative symptoms, where these second generations can help with both positive and negative symptoms. You might ask then, well, why don't we use these for just everyone then if they're less likely to cause side effects? And main reason is they can sometimes be 10 to 20 times more expensive than some of our first generation agents. Into some of our side effects of these second generations and some things that make certain medications stand out compared to other ones. When we talk about clozapine and olanzapine, which are 2 significant second generation antipsychotics and can be very effective, they're associated with some very serious metabolic effects. Weight gain is one of the most commonly reported side effects, and it can be pretty substantial. It can lead to other metabolic issues, including diabetes and dyslipidemia, or increased lipid levels. The metabolic complications can have some serious long-term consequences, leading to increase in cardiovascular events and premature deaths. So if you do place a patient on clozapine or olanzapine, you do need to closely monitor them for weight gain or any metabolic changes, and be pretty proactive with looking at those side effects. They like to ask questions about these two drugs with the metabolic side effects. So it's definitely something you want to put into your mind here. Let's focus on clozapine a little bit more now. And it is recognized for having superior efficacy compared to other antipsychotic agents, and it's a really valuable option. But it tends to have a bit more side effects also, which is a reason you don't just go straight to clozapine. One of the big side effects that we're going to talk about even has a REMS program for it, which is our risk evaluation and mitigation strategy program we've talked about with a few other drugs in previous quarters. You're going to reserve clozapine really just for patients that have had significant side effects or medical risks to taking the other antipsychotic drugs, or to patients that have not responded to the other antipsychotic drugs. When we're looking at the big side effect outside of the metabolic issues of clozapine we just talked about, we have to look at the REMS program side effect with agranulocytosis, which is our potentially life-threatening decrease in white blood cell count. It's essential to monitor for this. You have to monitor for their white blood cell count and their absolute neutrophil count. You have to look before you start treatment and regularly monitor throughout treatment. At first, you do it weekly, and then that's for the first 6 months, and then every 2 weeks for an additional 6 months. So there's quite a bit of monitoring you have to do for this drug. Another reason we reserve it really for someone who didn't tolerate a different kind of medication or didn't notice any response to a different kind of medication. It is pretty important to know what those lab levels show and when you need to stop your clozapine. If your white blood cell count falls below 3,000, you need to discontinue your clozapine. But that's not saying you have to permanently discontinue it. If it drops below 2,000, though, you need to permanently stop clozapine and never go back to it. Similar to our first generation antipsychotics, our second generation also carry that black box warning about an increased mortality when you use them to try and treat dementia-related psychosis in our elderly patients. And then there's also a black box warning that's specific for clozapine with myocarditis that you should be aware of. And I understand, very wordy slide, but it's kind of just throwing the rest of the side effects at you. For our second generation antipsychotics, a lot of these are going to look very similar to those first generation antipsychotics with this very similar slide. You can get hyperprolactinemia with increased prolactin levels. You can get elevated thyroid stimulating hormone, anticholinergic effects, orthostatic hypotension, sedation. With those elevated prolactin levels, you can get those neuroendocrine effects with gynecomastia, galactorrhea, menstrual irregularities or amenorrhea, as well as other sexual dysfunction. It can lower the seizure threshold, so especially use caution on any patients that may also have a seizure issue or epilepsy, and then it can prolong QT as well. This is all kind of reviewing as well, just getting those adverse effects together in one area of the lecture. But remember, all of them can cause agranulocytosis, but this is particularly a risk for clozapine, and it has that REMS mitigation program that you have to monitor the white blood cell levels for any kind of like marked leukocytopenia or low white blood cell count, especially with clozapine. Those patients, remember that they might present with like a high fever, weakness, hypotension. That decreased white blood cell count can lead to increased risks of infections. And then this picture that I have here is showing some of the necrotizing oral lesions that patients can get if they get a pretty severe agranulocytosis. When we're talking about our second generation antipsychotics or atypical antipsychotics, they can cause those extrapyramidal side effects like tardive dyskinesia, akathisia, dystonias, but it's less likely than when you're talking about our first generation antipsychotics. And then remember, when we're talking about our first generation antipsychotics, those EPS side effects are more likely with high potency and less likely with low potency. And then our second generations are less likely than any of the first generations. And then we briefly talked about, but remember that all of them can cause metabolic effects, but that's especially important to remember for your olanzapine and clozapine. And these metabolic effects can cause weight gain, diabetes, dyslipidemia. So you do need to start a baseline before you put your patients on any of these antipsychotics. And then especially if they're on those two particularly, you do need to monitor throughout treatment. There are various ways that you can administer these medications. Most patients are going to prefer an oral route. It's more convenient dosing. It's really suitable for the patient. They're generally well tolerated. It's easily adjusted based on the patient's needs. You might need to consider, though, doing a sublingual administration, especially if a patient is refusing to take their medication or trying to hide taking it from you. Sometimes that's called cheeking. You give them the oral pill and they shove it in the back of their cheek and open their mouth and you can't see it there. So they're not taking their medication, then they spit it out later. So sublingual administration is going to dissolve under the tongue, rapidly absorb, and ensure that they receive their prescribed dose. You can look at intramuscular administration. This is typically going to be reserved for like a severe acute situation in like a hospital, but there are also indications for long-term maintenance with like a depot type injection. And this is going to be a pretty good option if you do have someone that's struggling adhering to oral medications. And then a different route as well is going to be an inhaled administration, which is something that you can use, especially in like an agitated patient. It's going to work pretty rapidly and help calm the patient quickly and safely. Learned about the different types of antipsychotic medications with our first generation, second generation, a little bit more information about high potency, low potency, the different side effects of a lot of these. So now we need to explore, how do I take all of that information and figure out what am I going to do to start treatment for my patient? This is looking more at like an acute situation, like what do we initiate treatment for someone on? If it is a treatment naive patient, so this is someone that hasn't been on any antipsychotic before they're being seen to initiate treatment, you will look at one of these second generation antipsychotics. Aripiprazole is a pretty common first line option because it really has a favorable side effect profile and a lower risk of some of those metabolic effects that you might see with like our next one, olanzapine. You could also look at quetiapine. That also has a greater risk of weight gain, so you need to monitor that closely. Risperidone is a great option as well. And then ziprasidone is another option. Aripiprazole is probably one of the more common ones for like a treatment-naive patient, though. If it is someone that has come in and they've been previously treated, but they're not on something right now, what I would say is you restart what was previously working for them, what they previously thought was effective, as well as they tolerated, whatever antipsychotic that was. If that didn't work, whatever they were on before, or they're on something and it's not cutting it, you can try initiating any antipsychotic that they've not previously tried and failed. So first generation or second generation, it's going to depend on your patient, their history, what kind of side effects they had before. It is important to note, don't consider it a failure until they have been on the recommended dose for at least 2 weeks. Because like we said very early on in this lecture, you might notice some changes in the first couple days, but you're not going to notice anything significant for about 2 to 4 weeks. Step 2. So if step 1 didn't work for you, you've tried that, they're coming in, it's been a couple weeks, choose any antipsychotic for monotherapy that they haven't already tried and failed. So any of the other ones we've mentioned, if they haven't tried and failed that, you can try switching them to that instead. Unless they are coming in and they're not tolerating it because they're having pretty severe suicidal ideation, then you would consider doing clozapine instead. Step 3. So step 1, they came in, you put them on an antipsychotic, they were on it for 3-4 weeks, it didn't really work, you switched them to something else, a different antipsychotic, that hasn't worked. So they've failed 2 appropriately dosed antipsychotics for at least 2 weeks on each one. Then step 3 would be to initiate clozapine. Remember, we typically reserve clozapine for someone who tried and failed, they're not tolerating, or they have pretty severe suicidal ideation because of its side effects. It's very effective, but it's got pretty severe side effects. Oh no, we've done step 3, we've tried 2 meds, they've failed, we tried clozapine, that's failing. Where do we go from here? What's step 4, 5, 6, 7? Unfortunately, with antipsychotics, you can have a lot of trial and error for your patients. So where you go from here is retry monotherapy. So just a singular agent with any first generation or second generation antipsychotic that they've not previously tried and failed, to try and explore other options and other types of meds. You could consider combination therapy, but there's not too much evidence that combining different antipsychotic medications works very well for those who are already not responding to monotherapy. And then you have to be really concerned about the side effects because now you're amplifying the risks of side effects. Another strategy is involving some type of non-antipsychotic medication, whether it be a mood stabilizer, like meds we'll talk about soon for bipolar, some sort of antidepressant or anxiolytic, something else to address some of the other symptoms or maybe comorbid conditions that the patient is experiencing on top of their psychosis symptoms. When we're treating schizophrenia or using antipsychotics for any psychosis type patient, it is going to be essential to really look at the individual and look at their different needs and circumstances. And there are going to be some considerations that we need to take into place on picking our agent. If someone comes in with severe agitation, and you might have some of your classmates that were EMS or emergency room techs that can really tell you about this. First generation might be more appropriate, with haloperidol being one of the super common ones that you will see given. If a patient is agreeable to taking an oral medication with severe agitation, you might not see that, but you can consider giving olanzapine because it can be quite sedating. So that is an option. But haloperidol IM is probably going to be your option for like a combative, agitated patient. And you should probably give a diphenhydramine or benztropine with it if you're able, or shortly after, once they start to calm down, to reduce those extrapyramidal symptom risks. Because if you remember back to all the things we've talked about, haloperidol is a high potency first generation, more likely to give those extrapyramidal symptoms. To prevent or combat those extrapyramidal symptoms, you also give diphenhydramine or benztropine, an anticholinergic. So looking at the whole situation for your patient. If someone comes in and they're experiencing severe insomnia with their psychosis symptoms, you can look at quetiapine, because quetiapine, one of its major side effects is sedation. So it may improve their sleep if they can't sleep because it's more sedating. If someone is at risk for metabolic syndrome, so they're already overweight, they already have diabetes, they already have cardiovascular issues, they already have hyperlipidemia, consider giving a first generation antipsychotic or the aripiprazole. Instead of giving, remember, you don't want to give olanzapine or clozapine because they have a high risk for metabolic syndrome. If someone is elderly, similar to many other meds, you really want to start at the lowest dose possible to minimize side effect risks. And then a lot of these can cause QT prolongation, which can lead to dysrhythmias and torsades. So these ones in particular are ones that really have that risk associated with them. Started our patient on medication. We know the side effects that we're looking out for. So what sort of response are we looking for when someone comes in for an acute episode and we initiate treatment? What we're looking for is resolution of those psychotic symptoms. And we want to start seeing some improvement in that within the first several days. So within the first 2 to 3 days. It may again take 4 to 6 weeks to see a full improvement, but you're going to see from those first few days to the end of the first 2 weeks, you'll see rapid improvement. If you don't see rapid improvement by 2 weeks and really only minimal response, it's unlikely they'll have more response after that. So that's when that 2 weekish time period you consider switching to a different med. With those acute episodes, when we initiate treatments, what we want to see within the first week is a reduction in their violent, agitated tendencies, their hostility, any anxiety, any tension, a lot of, again, those positive symptoms. We want to see normalized patterns of sleeping and eating. It may take a number of weeks to get great response or full response. So by 6 to 8 weeks, we want to see them normalize overall. We want to see some improved self-care, normal thought processes, increased socialization, and just a steady improvement over those first 2 months. We're going to need to follow up with these patients fairly regularly if they've come in for an acute episode and we needed to initiate or change treatment. So after we initiate or change that treatment, we need some weekly follow-up with a mental health team, either to adjust their pharmacological medications, or if we need to adjust or add on any more psychosocial treatment. None of this treatment is just meds itself. They're going to need some sort of psychosocial treatment as well. After about 3 months of weekly follow-up with them, you can extend it a bit to monthly follow-up if they're continuing to improve and continuing in remission. At every single visit, though, you do want to make sure that you discuss their medication benefits. Are they benefiting from it? Are they improving? Are they doing well? Discuss those side effects. Are they experiencing any of these things? Remember, especially with those extrapyramidal symptoms, you need to catch it early because especially if they get that tardive dyskinesia, a lot of it can be irreversible. So you need to always be on the lookout for that. Always looking out for your metabolic issues, looking out for prolactinemia, looking out for that sexual dysfunction, looking out for a lot of those very common symptoms, not just the rare ones. And then always make sure and check on their adherence. Are they adhering to the medication? Does it match up? Are they saying they're doing well, but you can see that they're not with how they're acting and responding? So kind of match up their adherence with how they say they're doing. Okay, we have successfully managed our patient's acute episode of schizophrenia. Go us. We're great clinicians. It's going to be crucial to continue their antipsychotic therapy indefinitely in order to maintain stability and prevent relapse to another acute episode. There is a difference in opinion here depending on where you read, but most places say they need to continue on their maintenance therapy for at least 5 years of successful treatment. But many sources say that it really needs to be indefinite because this isn't a cure for their schizophrenia. This is just treatment of their symptoms. You can also, for maintenance therapy, consider doing like a long-acting depot antipsychotic. And they're really good for maintenance therapy because they tend to have lower relapse rates compared to oral medications. You can increase adherence because the dosing interval is pretty good. It's every 2 to 4 weeks as an injection. And then the patient has to come in for their injection, so you know that they're being compliant with their treatment regimen, and they're not having to take something every day. The drug levels tend to be a bit more stable between doses. And then with the injection, you tend to be able to decrease the total dose over time, which can also reduce the risks of side effects when you're taking just this maintenance therapy. Primarily looking to achieve with our maintenance therapy when we're looking specifically at schizophrenia is improving our overall quality of life for our patient. Key objectives being minimizing their symptoms, reducing their functional impairment, getting them back to engaging in everyday activities, enhancing their independence and their quality of life, managing all of those side effects and monitoring all of those side effects that we talked about with all these medications, trying to avoid any relapses, establishing really a stable treatment plan to kind of prevent the return of any acute episodes, and then promoting recovery, promoting them and empowering your patient to take an active role or self-determination in their treatment and recovery. Really encouraging full integration into society, a sense of belonging within their community, and participating fully in any social, educational, or vocational activities that they wish to belong to, and setting up and encouraging personal goals and aspirations, really to overall improve their well-being and improve their mental health as well. Research is also going to show that kind of employing like a multidisciplinary intervention with all of these things, with meds, psychosocial, promoting self-recovery, can really decrease hospitalization rates, lower the symptom severity, and improve their overall feelings of well-being. It's going to be important to kind of look at some algorithms and combine it with family education and psychotherapy and maybe some employment or education assistance really over a 2-year period to really try and get the greatest improvement we can with quality of life for these patients. Education is going to be super important for any patients you're placing on an antipsychotic or any schizophrenic patients that you're treating with an antipsychotic, because some patients might view these side effects, like your extrapyramidal side effects, the tardive dyskinesia, the sedation, the dry mouth, as a sign that the medication you're giving isn't working or even worsening their symptoms. So if you're able to let them anticipate what some of those side effects may prevent, it may cause them to not like unilaterally decide, I'm not taking this med and not adhering to the medication. If you can educate them on what the risk of discontinuing the med would mean, the recurrence of all of those acute symptoms they had, you can hopefully try and prevent acute episodes from happening and increasing their adherence. Many times when I've talked to you all about patient education strategies and enhancing adherence, not just with these psychiatric issues, but even when we talked about like hypertension, heart failure, those sort of issues, encouraging family members to help oversee medication management can really help increase adherence for your patient and provide additional support for your patient and really track any side effects or concerns. It's always going to be important to really build trust with your patient and their family and establish a really strong therapeutic relationship. Kind of foster a supportive and open relationship with effective communication, allow for discussions, don't add any barriers to their treatment. Let it be open and hear out what they're saying. So that way you can make sure that you're mitigating any side effects and mitigating any non-adherence that you might be subject to. And then again, we talked about how the IM depot preparations can be good for long-term maintenance therapy because they're given once every 2 to 4 weeks. They have to be done in the office. They don't need to worry about taking a daily oral medication. And you can see that they're being adherent because you're seeing them in the office to give them that medication every 2 to 4 weeks. When you're checking back in with your patient and seeing how they're doing and what sort of benefit they're getting from the medication, these are going to be some of the residual symptoms that you're going to be looking out for. If they aren't getting adequate control of these symptoms, that's where we might need to look at either a dose adjustment, we might need to look at switching to a different medication, or adding on one of those non-antipsychotic medications like a mood stabilizer, an anxiolytic, SSRI, depressive type medication. So we just always want to look out for some of those residual symptoms that they might be getting. And again, making sure that they're adhering to their treatment plan, checking in with that, as well as not just their medication, but they are doing the whole multidisciplinary psychosocial aspects of their treatment plan as well. Our course for every patient is going to be different. There does tend to be an episodic nature of this illness, and they might get intervals of partial remission where they're doing really well for a while, but their symptoms might not fully disappear. And then they get acute exacerbations where they're getting these acute disruptive distressing symptoms. The outcomes tend to be pretty diverse, and some people get really great stabilization and improvement in their condition over time, where others might get progressive decline in both their mental status and their social functioning, leading to really big challenges and increasing challenges in their daily life. And that's where we have to explore those different steps to try and get them into the best remission that we can and the best maintenance that we can. So we really have to make sure that we educate them on the importance of maintenance therapy in order to reduce that relapse risk. And while maintenance therapy can reduce our relapses, it might not entirely prevent long-term deterioration or intermittent episodic acute exacerbations. So just really having a real conversation with your patients on what this condition looks like for them and what your goals are and your patient education is for your patient, and treating this condition together as a team. Gone over our antipsychotic medications. We did a real deep dive into schizophrenia, and now we are going to move on to bipolar disorder. When we're looking at bipolar disorder, it's going to be characterized by these mood fluctuations. And you're going to have some periods of abnormally elevated or irritable moods known as mania or hypomania. You're going to have episodes of abnormally depressed moods, leading to feelings of sadness, hopelessness, or lack of interest in activities. And then you're going to have intervals where the individual might experience stable moods, known as euthymia, and have periods of normalcy. The symptoms typically begin again in adolescence or early adulthood. And then if you do have untreated episodes, these can last for months. So if you have someone that doesn't know or isn't adhering to their treatment for their bipolar disorder, some of these fluctuations in moods can last for a very long time. Diving in a little bit more into these mood episodes. So with these different types of moods, you can get like a euphoric mania or a pure hypermanic episode. And this is going to be an extremely elevated mood state and often accompanied by increased activity, energy levels, decreased need for sleep. They might have euphoric or irritable moods, ideas of grandiosity or inflated self-esteem, racing thoughts and rapid speech, impulsivity. They might have poor judgment. They might have some of those positive psychotic features we talked about, like delusions and hallucinations. And then you've got hypomanic episodes or hypomania, and it's going to be a milder form of that mania that doesn't necessarily impair social or occupational functioning, but they still have elevated mood and increased energy level, just less intense than that full mania. They still need a little bit less sleep. They tend to be more talkative than normal. They're more productive, more creative, but that can easily escalate into a full hypermanic episode if it's left untreated. You've got your major depressive episode, an intense state of sadness, hopelessness, depressed mood, loss of interest in activities. They can have significant changes in their weight, significant sleep disturbances, difficulty concentrating, or even suicidal thoughts or behaviors. And then there's a mixed episode. It's a combination of manic and depressive symptoms that happen either simultaneously or in rapid succession. They're bouncing back and forth between both mania and then suicidal ideation or emotional volatility. When we are starting to look at our medication options, our pharmacologic treatment for our bipolar patients, we need to look at what type of episode are they having. Our preferred treatment option and whatever we initiate treatment based off of is going to be what type of specific mood episode they're having, whether that's mania, hypomania, or depression. Our common options that you saw on some of the other slides are going to be our mood stabilizers like lithium or valproate, our atypical antipsychotics or those second generation antipsychotics, and antidepressants, which we do need to use quite cautiously. We'll see why in a few minutes here. We might need to kind of, after an acute episode, consider adjusting the maintenance regimen in order to provide some better stability for our patient. And then looking at our mood stabilizers, we're going to start off with mood stabilizers. We're going to start off with lithium. Lithium is going to be our preferred treatment and drug of choice for any of our patients experiencing an acute mania. So again, we're using those for acute mania as well as for bipolar depression and long-term management, but it is our drug of choice for a patient with acute mania. Our time to benefit for those anti-manic effects typically begins in about 5 to 7 days, but we're not going to see our full benefit for a few weeks, similar to a lot of the other medications we've talked about. And we don't quite know how it works or why lithium helps with this, but our theory is that it might stimulate inhibitory neurotransmission and kind of modulate the excitatory transmissions within the brain. Lithium's pharmacokinetics are really quite unique, so I go into them a little bit in detail here because there's nothing like it. It's rapidly absorbed, so it quickly enters the systemic circulation and then widely distributed throughout all of the body tissues pretty effectively. And then it's not metabolized. It remains unchanged throughout the body and is excreted through the kidneys unchanged. You do have to use caution in anyone with renal impairments, and you might need to adjust the dose or lower the dose if they have renal impairments. It is highly influenced by sodium levels. So if someone has hyponatremia, so low sodium levels, it can actually lead to an increase in lithium levels and a potential toxicity. And then with diuretics, because diuretics can affect the sodium levels, it can also affect then the lithium levels. So you need to use caution with any diuretics. Similar to that vein of thought is we have to use caution with diarrhea, dehydration type symptoms because it can elevate the lithium levels and again lead to toxicity. Dehydration, if you look at it, can lead to higher lithium levels. Increased sodium intake can lead to lower lithium levels. Decreased sodium intake can lead to higher lithium levels. Lithium and sodium, they're kind of like two peas in a pod here. If one goes down, the other goes up. So if you think about anything that's going to be decreasing sodium levels, like dehydration, diarrhea, anything like that, or a diuretic, something like that, it's going to increase your lithium levels. If you have anything increasing sodium levels, like a high salt diet, something like that, it's going to lower your lithium levels. So you have to monitor it pretty well. These are our early and symptoms that usually subside within a short time period after initiation of treatment. But a lot of patients, when they first start taking lithium, may experience GI side effects with nausea, diarrhea, or some sort of abdominal bloating. They also might get some of these other side effects that typically happen early, and when they continue treatment, they start to go away. These are some of the side effects that you have to worry about a little bit more. Like I said, early on and they go away, they can get some GI side effects, but with longer treatment at therapeutic levels, even you have to worry about like a tremor. If they do experience this tremor, you can reduce the incidence of it with giving them some sort of beta blocker. A lot of patients, like 50 to 70% of patients, will get polyuria, so they're urinating a lot. You can give them amiloride, which is going to decrease the amount of urine that they are experiencing. You also, again, you don't want them to get dehydrated, so that's why you're going to instruct your patient to drink 8 to 12 glasses of fluid daily. I know that seems sort of counterintuitive because isn't that going to make them pee even more? But you don't want them getting dehydrated because you don't want the loss of sodium from peeing all the time to then cause increased lithium levels and lead to toxicity. You do need to assess kidney function before prescribing. Like I said, if they have some sort of decreased kidney function, you might have to adjust your dose or try and pick a different medication. It can cause goiter or hypothyroidism. This is something that you're going to have to look at a thyroid panel before you prescribe, and then at least once a year in order to make sure that they haven't gotten hypothyroid. If they do, just like other hypothyroidism we talked about, levothyroxine is going to be your treatment of choice for that. And then it is teratogenic, so you do need to use caution in anyone who is pregnant or could become pregnant. You do have to be aware of some pretty big black box warnings. There is a risk of liver damage, and you need to monitor liver function regularly to make sure they're not getting hepatotoxic. There is a potential risk for pancreatitis, so make sure you and your patient are watching out for any abdominal pain or prolonged GI symptoms. And then again, risk of teratogenicity, so caution for anyone who is of childbearing age and able to become pregnant. Lithium is one of our drugs that has a narrow therapeutic index. So if you remember, narrow therapeutic index means what is an effective dose is very close to what is a toxic dose. So we have to measure our plasma drug levels pretty routinely to avoid toxicity and make sure it's effective. When you first start treatment, you're going to be measuring every 2 and 3 days until they're at a stable level. Once they've been stable for a while, then you can push off that monitoring to once every 3 to 6 months. But if they're starting to get symptoms, they might need to come in sooner than that. If they do have elevated levels, you need to interrupt or stop your dosing to make sure it gets out of that toxic range and gets back to just the therapeutic range. If it's extremely elevated, you might have to do hemodialysis to get it out of the body. There are different things that can increase risk of toxicity. So any sort of underlying renal insufficiency. So that's again why if someone has decreased kidney function, we might need to use a lower dose. If there's any sort of volume depletion, so if someone's on a diuretic or they're dehydrated, remember 2 peas in a pod. So it's gonna, if the sodium level's going down, it's increasing our lithium levels. So you have to watch out for that. And then our older patients are going to be highly susceptible to adverse effects and toxicity from lithium. Lots of things we have to monitor with lithium, just to review those all together on one side. Because of that narrow therapeutic index, we have to measure our trough concentrations. We want to make sure it's getting into that target maintenance level, so that's way it's not toxic, but it's still therapeutic. Again, first starting treatment, every 2 to 3 days you're measuring until they're stable, and then pushing it off to every 3 to 6 months or so, unless they're showing signs of toxicity or it not working. You need to assess your renal function, because if they have decreased renal function, it can lead to increased levels in toxicity. You need to monitor your serum calcium, which can cause some metabolic effects. We didn't really touch on that, just as an FYI. You need to monitor your thyroid function, because that big side effect of hypothyroidism. You might want to monitor their weight as well. And then anyone over the age of 40 or has pre-existing cardiovascular conditions, you want to monitor an EKG on these patients as well. But the big ones I want you to remember are your drug levels, because of the narrow therapeutic index, renal function, because it's going to increase the risk of toxicity, and thyroid function, because it can cause hypothyroidism. There are some drug interactions that you should be aware of. Diuretics, we've already talked about it. Diuretics can promote loss of sodium, because sodium and water are following each other, and this can increase the levels of lithium within the body, which is going to increase the risk of lithium toxicity. NSAIDs can also raise lithium levels by up to 60%. So you want to avoid NSAIDs if you can avoid them. Aspirin does not increase these levels. It's kind of its own little guy that's not quite NSAID. So you can use aspirin and lithium at the same time. And then any anticholinergic drugs, because anticholinergic drugs, one of the big side effects is urinary hesitancy. So with that, you could lead to bladder issues, because these drugs are causing polyuria, or increasing the amount of urine, and then now you have urinary hesitancy, so it is not allowing them to get rid of that increased amount of urine. It's leading to a full bladder, and it's leading to other issues with all of that. So avoid any antihistamines that could cause that urinary hesitancy. Another type of drug we can use as a mood stabilizer is some of our anti-epileptic drugs. Main one that we'll see is divalproex sodium. It does come in kind of 3 different formulations, but the divalproex sodium is what you're going to see used most often when it comes to bipolar instead of seizure capacity. When we're using these anti-epileptic drugs for bipolar, they're usually used at a lower dose compared to when you're using them for seizure disorders. And we're aiming to kind of act for mood stabilization without causing excessive sedation or other side effects that we see when you're using it at the anti-epileptic doses. Mechanism, again, one of those kind of unknown mechanism, but it's involved in multiple pathways involving neurotransmission within the brain. It's going to be a first-line treatment option for bipolar disorder, but a lot of times the books will say lithium is your go-to choice. That might be different than practice, but books say lithium, but this is a first-line option. It is effective for acute manic episodes and prevention of relapse into mania. It is comparable in efficacy to lithium in managing our bipolar disorder. But lithium is often preferred because it reduces suicide risk to a greater level, and it's better at preventing our relapses. Divalproex sodium, though, it has a really rapid onset of action, and it is considered safer than lithium is. So that's one of the reasons you might use this over lithium. Using divalproex sodium or valproate, you can use it for acute treatment of mania. You can use it for prevention of relapse or maintenance therapy. You want to use caution if they are having depressive episodes, though. It doesn't work as well for the depressive episodes of bipolar. Like lithium works for both. This works mostly just for mania. You also want to use caution if anyone has any liver impairment or potential for liver impairment, because we'll see on the next slide that it is hepatotoxic. And then you'll see it used, we'll talk about it later this quarter, for migraine prevention, and it is an anti-epileptic. Some of our big side effects, you might have an increased bleeding risk due to thrombocytopenia. There's some black box warnings very similar to our lithium with teratogenetic effects, hepatotoxicity or liver failure, pancreatitis. You can still get some of those GI disturbances, very similar to lithium as well. And then some other side effects like sedation, tremors, alopecia, weight gain. A lot of these are very similar. As you notice, I don't have anything bolded on this slide, but there are some things that you have to monitor with your divalproex sodium as well. Because of that thrombocytopenia, you need to look at your CBC count with differential to get your platelets. You do still need to measure the trough concentrations of this to make sure it's still in that therapeutic range. You're going to be looking at lipids and glucose because of the weight gain issues that this med can have. And then because of hepatotoxicity, you're still looking at those liver function tests. Another anti-epileptic drug that you could use for an acute manic episode, not for a depressive episode, would be carbamazepine. Again, usually used for an acute manic episode or prevention of relapse into mania. Some of the side effects that we have with this one, the big one I want you to be aware of is aplastic anemia or agranulocytosis, as well as Stevens-Johnson syndrome. So you do need to obtain a CBC at baseline and then periodically check it to make sure that they are maintaining where they should be. This is just an FYI, another type of anti-epileptic drug that is an option for bipolar disorder, lamotrigine. We'll go into more details on lamotrigine when we get to our anti-epileptic section. You can also consider the atypical second-generation antipsychotics. And when we get into our treatment algorithms in a few slides, you'll see where these guys kind of fit into our treatment for this. You can also consider as an adjunct add-on therapy your antidepressants. This is going to be for someone in a depressive episode. So it's an option for add-on therapy in an acute bipolar episode. It must, let me yell it out here, must be used with a mood stabilizer. You don't use these by themselves because it may actually induce a mania. It may provoke a manic episode if used by itself. So it must be with a mood stabilizer. If it's not used with a mood stabilizer to prevent a manic episode, you may treat their depression too well and send them in flux across the spectrum to a manic episode. We've talked about our different kinds of medications we can use for our bipolar patients. Let's look at the different types of mood and how do we approach this. First, we're going to look at an acute therapy for someone in a severely manic episode. So a severely manic episode. Our preferred treatment is going to be combo therapy. So not just one thing by itself, it needs to be a combination if they're in a severe manic episode. We need some sort of mood stabilizer. A lot of the textbooks will say lithium. You might see divalproex sodium used in practice. It's also an acceptable option, but one of them, lithium or divalproex sodium, plus one of our second generation antipsychotics. These are the four you'll typically choose from. Your aripiprazole, olanzapine, quetiapine, or risperidone. And you'll notice when we were talking about antipsychotics for a treatment-naive patient with schizophrenia, these are your first line options for that usually as well. It's going to take usually 2+ weeks for a response, the response that you're wanting to get. So it's not an overnight treatment that they can have. It's going to take some time. So what I want you to know for an acute severe episode, combo therapy with lithium or divalproex sodium plus a second generation antipsychotic. This chart shows you all of the possible first line options, but as I have on the right here bolded, combination is preferred. And you're going to see all the ones on that right column. The first med is a second generation antipsychotic plus lithium or divalproex. In red and bold here, if they are in a severe manic episode, you need to stop any antidepressants. Antidepressants can send people into a manic episode, so you need to stop them if they're in a severe manic episode. This is if it's an acute hypomanic episode or just mildly manic episode. You're adding on treatment to make sure they don't progress into an extreme severe manic episode. If it is just hypomania, you can do monotherapy. And your preferred option for monotherapy is going to be a second generation antipsychotic. You can use the second generation antipsychotic as a mood stabilizer. Your response is still going to take 2+ weeks though. As you can see, this can be very complicated. This algorithm is just FYI to show you how complicated it can be. Now we are in with a patient with an acute depressive episode. If they have an acute depressive episode, your first line treatment option is going to be monotherapy with a second generation antipsychotic like quetiapine or lorazepam. Your second line option, if monotherapy isn't working with one of those, is going to be either going to a divalproex sodium by itself, a combo of a second generation antipsychotic plus like fluoxetine, which is a antidepressive SSRI, or a combo of a second generation antipsychotic plus lithium or valproate. Starred here, bolded here again, just because they are in a depressive episode, you will not put them on an antidepressant alone because this can send them into mania. Gotten our patient through their acute episode, whether it be mania or depression, we've gotten them through that. They're stable now. Now we need to figure out what we're going to do for a long-term preventative treatment. Our purpose here is to prevent recurrence of both mania and depression. Our general guideline for this is really going to be select what worked in the acute setting. Use that same regimen that successfully treated their acute bipolar mood episode, whether that be mania or depression. So again, if you have them through that acute episode for long-term preventative treatment, use what worked acutely. We know it works. Let's keep them on it to keep them stable. Second line, if they're not tolerating that acute med for maintenance, then you'll look in order of preference, lithium. Lithium, again, one of our drug choices for our mood stabilizer versus divalproex sodium, and then quetiapine, lurasidone, or lamotrigine are our second generation antipsychotics. And then we won't get down all the way to third line, but know that there's trial and error all the way down the line. As with any treatment regimen that you're using, any algorithm you're using, you always have to take considerations with what you're picking based on the individual patient. You have to look at the side effects, you have to look at their comorbidities, what they're currently taking, can they afford this medication? Again, those second generation antipsychotics, they cost a whole ton of money. So can they afford that if that's what you're trying to pick for them? Look what they responded to before. If they responded to that before and came off of it just because they came off of it, put them back on it. It worked before, let's try it again. What if we have a patient that they are on monotherapy with their lithium or whatever it had worked with them in the acute setting, and they keep getting relapses? They have had 3+ relapses, or that monotherapy is kind of helping, but not really. They're still getting a lot of symptoms slipping through. Throw the kitchen sink at them, like my little picture here says. It's going to be a combo therapy similar to our acute episodes of mania. It's going to be lithium or divalproex sodium plus a second generation antipsychotic. A certain population you have to look for. As you saw, most, if not all, of these drugs are teratogenic, and when we looked at bipolar disorder, it tends to appear in adolescence and early adulthood, so like teens to 20s. Many of those patients are going to have the ability to become pregnant. So you need to provide guidance to anyone of childbearing age who's able to become pregnant. They can't a lot of times just stop their bipolar medication. That's not going to be safe for them or their baby either. So you need to have some preconception counseling for your patients about implications of their disorder and medication management. You're going to prefer monotherapy and aim for the simplest treatment regimen that you can with the lowest effective dose to try and mitigate those risks. You're also going to want to make sure with anyone pregnant, they need to be on folic acid, but especially if they're on these bipolar medications, to reduce the risk of neural tube defects. Some medications with the highest risks are going to be divalproex. It can have potential long-term cognitive effects on the child and neural tube defects. And lithium. Lithium can cause congenital cardiac malformations, and lithium enters the breast milk. So that's part of the reason I showed you all of these options, that there are other options that you might need to consider switching them to or figuring out what works for them if they're wishing to become pregnant or they do become pregnant. Our last section for this lecture are CNS stimulants. Our CNS stimulants are working through two main actions. They're either enhancing neuronal excitation, so increasing the activity of our neurotransmitters, or they're suppressing neuronal inhibition, meaning they're decreasing the activity of the inhibitory neurotransmitters. They're going to be indicated for ADHD or attention deficit hyperactivity disorder in order to improve focus and attention, and sometimes used in narcolepsy also to manage excessive daytime sleepiness. Important to note, for behavioral effects, they are working by reducing negative behavior. They do not create positive behavior. Rather, they're really just helping diminish disruptive or negative behaviors. Starting off with our amphetamines. So our examples of that are amphetamines, dextroamphetamine, lisdexamfetamine. So if you didn't get through there, a lot of them have amphetamine in them. Their mechanism of action is going to be to release norepinephrine and dopamine, which is going to stimulate the release of these neurotransmitters from the presynaptic neurons, and inhibit reuptake of norepinephrine and dopamine, which is going to increase their availability through that synaptic cleft. We're primarily using these for ADHD and narcolepsy again. And then remember, they aren't going to suppress rowdy behavior. They just improve attention and focus. The negative behavior reduction is because the patient's now able to concentrate. These meds aren't going to give the kid like good study skills or create other good behaviors. You just need to teach them this. They need to be learned once those disruptive behaviors are now reduced from the medication. These are our effects that we can see on the central nervous system with our amphetamines. So on the central nervous system, you might see an increase in wakefulness and alertness. It'll reduce fatigue, elevate mood. It can augment their self-confidence and an initiative drive. It can cause a sense of euphoria, increased talkativeness, increased motor activity, improve their task performance, and it can also suppress appetite. In the cardiovascular system, your amphetamines can increase heart rate and cause tachycardia, increase AV conduction, increase the contractility and contraction strength, and cause dysrhythmias and hypertension. Now, patients can build tolerance to these medications, and tolerance can build up to a few things in particular. The mood enhancing effects over time. It can reduce the response for that mood enhancing effect. The suppression of appetite, it'll decrease effectiveness in suppressing appetite. And then it also has a diminished effect on the cardiovascular stimulation with continued use. So it's going to decrease some of those cardiovascular effects that we talked about. People can develop a physical dependence to this medication, and it can lead to something called abstinence syndrome if they abruptly discontinue their stimulant. If this happens, it can lead to exhaustion, depression, prolonged sleep, excessive eating, and really a craving for more amphetamines because they're physically dependent on them. If you think about how these are acting to increase norepinephrine levels and the effects that they're having on our central nervous system and cardiovascular system, you can imagine what our side effects are going to be. And it's going to be a lot of these just effects that they have on these symptoms. It can cause insomnia and restlessness. It can cause weight loss because of the suppression of appetite. Because of the increased contractility and increased heart rate, you can get tachycardia, hypertension, angina, dysrhythmias. It can also cause some psychosis with hallucinations and delusions. Because of some of those CNS effects of mood effects like euphoria, there are also people that abuse the use of your stimulants, like your amphetamines, and use it for those euphoric effects. And for that reason, it is a Schedule II medication, so it is a controlled substance. Methylphenidate, which many of you probably know as Ritalin, is another option as a CNS stimulant that you can use for ADHD, and it works very similarly to your amphetamines by releasing norepinephrine and dopamine and inhibiting their reuptake as well. Our adverse effects, therefore, are going to look very similar with insomnia, restlessness, weight loss with appetite suppression, your cardiovascular effects with tachycardia, hypertension, dysrhythmias, angina, as well as some of the psychotic features with hallucinations and delusions. Because of that euphoric mood alteration potential, it is also an abuse potential medication and a controlled substance as a Schedule II med. Another option is our norepinephrine reuptake inhibitor, atomoxetine, and this one's working slightly different. It is not necessarily releasing norepinephrine and dopamine. It is selectively inhibiting just the reuptake of norepinephrine, and by doing that, it'll increase those norepinephrine levels in the brain. It has a little bit slower onset of action compared to our stimulants with a 2 to 4 week time period for therapeutic effects, but it doesn't have the abuse potential that our stimulants like methylphenidate and amphetamines do. So it is not a controlled substance. Some of our side effects that we can see, though, as you see, none of these are bolded for you, but just to let you know, you can still get some GI side effects with nausea and vomiting or dyspepsia, some reduced appetite, drowsiness, mood swings, trouble sleeping, suicidal ideation, especially in children, or hypertension. Specifically at attention deficit hyperactivity disorder, or ADHD, we're looking for signs and symptoms of inattention, like difficulty sustaining attention to tasks or frequent careless mistakes, trouble organizing tasks and activities, or often losing items that they need to complete their tasks. They may also have hyperactivity, which is like fidgetiness, difficulty remaining seated, excessive talking, running about or climbing in inappropriate situations, as well as impulsivity. So blurting out answers before someone even completes a question, difficulty waiting their turn for something, or interrupting or intruding on other people's conversations or games. When we look specifically at ADHD, we're really looking for combination of medications as well as cognitive behavioral therapy, or CBT. So a stimulant or atomoxetine plus combination behavioral therapy. Our first line options when we're looking at ADHD is going to be those CNS stimulants that we talked about. So our methylphenidate, our amphetamine mixture, which is known as Adderall, or our Vyvanse, our lisdexamfetamine. We use these to try and increase attention and improve the patient's ability to focus on tasks. And again, increase that task focus, increase concentration, and reduce distractibility of our patient. Again, they're not suppressing the rowdy behavior, they're just improving attention and focus. And because that negative behavior is reduced, and because they're able to concentrate, you have to teach them the good skills to do now that they're able to stop some of the disruptive behavior. So those stimulants, your methylphenidate, your amphetamine mixture, your lisdexamfetamine, those are your preferred agents for ADHD. The alternatives are going to be your atomoxetine, which is your norepinephrine reuptake inhibitor, or an antidepressant like bupropion or nortriptyline. This is your big complicated algorithm. So for those people that this is how you learn, being able to work it through the lines for your patient or work it through the algorithm to figure out what the best option is.